Welcome to Health and Veritas. I'm Harlan Krumholtz.
And I'm Howie Foreman. We are physicians and professors at Yale University. We're trying to get closer to the truth about health and healthcare. First, Happy New Year to our listeners and to you, Harlan.
Thank you, Howie.
And it's great to be back.
Happy New Year to you.
And we're back in the studio, which is always fun.
It's always good to see you. I haven't seen you in a while.
Oh, it's been fun. It's good to see you in person. Ordinarily, obviously, we have a guest several times each month, but at least once a month, we've been trying to do one of these. And there is a lot of news that we can cover.
Yeah, the big news is a big deal, man. You're going to Washington tomorrow for some big event. What are you doing?
I know. We're taping this on Tuesday, late afternoon, because I do not like to travel.
You do not like to travel.
And for me to get on a train for 11 hours tomorrow, there and back to Washington to see Vivek Murthy, our Surgeon General, there's a celebratory event that will sort of summarize the accomplishments of the Office of the Surgeon General that they're putting on tomorrow. And a lot of people I know will be there. So it'll be nice to see. I'm hoping the event goes well. It's a very quick trip, but I want to do it, and I'll report back next week on how that goes. But what do you have on your mind? Like, tell me what's a hot topic for you right now?
Well, I don't know about a hot topic, but I thought I might start off with, you may have seen this Gallup poll that came out about how people view the U.S. healthcare system.
Yeah,
Did you see
yeah.
it?
Not good.
Well, it's interesting to me, so only about 44% of Americans rate U.S. healthcare as excellent or good. That compares to about 64% in 2001. I think it's this general trend about how people feel about institutions.
Yes.
But coverage fares even worse with just only about a quarter, about 28% rating it positively, far below the high of 41%. But 41%, there's less than half of people feel that coverage is good. You and I haven't spent very much time talking about this, what is it, an assassination that occurred in New York.
Yeah.
We talked a little bit, but in this outcry, there was no sympathy at all for the family or the person. I don't want to say no. What I'm just saying is that we saw a lot of people just focusing on anger at United Healthcare in particular, but also just the general industry. I think this poll sort of represents some of that, but it simmers even more, that I just saw so many things on social media, not the crazy stuff on social media, but actually people that you wouldn't expect to be saying things that were disrespectful, when this kind of thing happens. And I don't know, how did you internalize? What did you think about all of that?
I was most offended by the people inside the industry who were attacking the health insurance industry, writ large, without acknowledging that we all play a role in this. And I'm going to hit on a couple of those issues today, but there are real problems in healthcare. Healthcare is too expensive in the United States, particularly for out-of-pocket payments for the middle class. If you're wealthy in America, you're getting good access to healthcare and you can afford it. If you're very poor, you're getting pretty good health care, but certainly not the level of coverage that wealthy people get. But there's this vast middle. You have studied this in a scholarly way with talking about financial toxicity and the exposures that people have, not to disease, but to actually financial harm from their own health care. And I think that's a topic that is resonant with most people. Everybody has some bad experience with how our health insurers pay for things.
Yeah, and so here's how I thought about it. By the way, this poll also said that 71% of people think the quality of the health care they receive is excellent or good. So it's sort of like Congress. They hate Congress, but they continue to reelect their own person. It's kind of like, people love to hate health care, but they still like the health care they're getting. I mean, you'd like to see it higher than 71%, but still pretty high. I just didn't understand why people couldn't separate this more, because this is obviously, in my view, someone who's mentally ill, right? This is a troubled individual who, did a heinous act. There's no way we should be discussing anything connected to that as being a reasonable issue. Now, we should be discussing healthcare all the time because our healthcare system has got so many flaws and we should be addressing them and thinking about systemic solutions. But to pair the discussion as if it's, it was as if it's no wonder that this happened. No. This is not any sort of rational response to something that happens. This is a mentally ill individual who took an unforgivable act, and there's something wrong with this kid.
Right.
So anyway, that's how I sort of felt about it, that we shouldn't have been mixing these issues. We should be talking about them separately. What do we do when people have access to guns? They're mentally ill. They're pursuing a course like this. That was what that discussion should have been about. This other discussion should say that, it's not like he had a point. He doesn't have a point. He just assassinated someone.
And the insurance system, we've talked about this many times in the podcast. There's actual fraud. There's actual bad behavior. And that occurs in almost any industry. Put that aside, because we're not going to excuse that. But much of the behavior that people hate about health insurance companies are things that have been thrust upon them by employers and by Medicare Advantage plans that set the rules up.
The structure of our system creates perverse incentives.
Best way of saying
which has ultimately stripped our profession of its mission, because now it's become just so businesslike.
That's right.
And we're going to pay the price for that for a long time.
But again, there are real reasons why those things were introduced. Spending on healthcare has been very expensive. Companies have tried to figure out affordable ways. Individuals are choosing Medicare Advantage plans. So there's a lot there.
Yeah. So we'll take this up in other shows, but I just wanted to
No, I'm glad you brought it back
to
up.
bring that up. So, okay, what's on your mind?
Yes, I'm going to do bird flu again, and I know like it
Oh,
feels,
no, somebody just died, right?
I know, exactly. So I wanted to start off with that. So there's 66 human infections in the current outbreak, 129.
Can I just ask a question?
Yeah.
When people say that, there are lots of people who've been sick. I've heard so many. I was sick for a while.
Right.
I didn't get tested. How do they identify these people? Because I always wondered, who's showing up to have the surveillance done?
That's correct. So 63 of them, if I'm getting this right, because I don't have the data in front of me, I believe 63 of them were people on farms that developed symptoms that were relevant enough that they went ahead and tested them. So it's not
So the
a
public health
prevalence
authorities
testing.
are sort of looking at a place where they're concerned, and they're saying, like, let's test these people.
Right. And the people are presenting to emergency rooms with conjunctivitis. So they're testing those. 3 people, if I got the number correct, in the United States have been detected on the sort of prevalent screening tests that they do for flu in a certain subpopulation. If I get this right, 1 in California, 1 in Missouri, 1 in Louisiana. The case in Louisiana is the one that you're talking about. Unfortunately, a woman over 65 with comorbidities died. And it is not surprising if you talk to people that H5N1 bird flu would kill people, particularly those at very high risk. It's also not surprising that the farm workers, who are generally much younger and are not always getting a pulmonary infection, but getting a more mucosal infection of their eyes, are not dying of it so far. But this makes people worried.
And she died of pulmonary
complications of this. That's how they're describing it.
Yep.
She and the case in Canada, which is not included in my 66, which was in a 13-year-old, I think, girl who was what you have taught me is class 2 obesity now. That young woman not only survived but recovered fully, but she had had a severe case as well. In that case and the Louisiana case, mutations were found in the testing that showed that the virus had attained the ability to infect pulmonary cells. The good news is it does not appear that mutation was obtained when they were infected. It was obtained as it mutated inside their own body. But it does worry epidemiologists and pulmonologists that we now are seeing a path that the virus can take to start to become more infectious in humans and lead to more lethality. And so that's why people are more worried about those 2 cases. And so it's raising red flags. On the other hand, there's no evidence of human-to-human spread at this point.
And it does seem like this isn't like when we were in early COVID, where people were, I mean, we're not seeing that.
There at all yet.
We're not seeing that. And there are some reports, like New England Journal, I believe, talking about people not being hospitalized,
That's right.
Largely,
the I think 40 or roughly 40 of the 63 farm workers are dairy farmers, and it's mostly probably milk being squirted in their face. The poultry workers, I'm not familiar with that work, and I don't think you are either, but apparently when they're slaughtering the birds after an outbreak occurs, they're working through these birds really quickly and getting rid of, I don't know, and that's the exposure happening there. It's not shocking that the farm workers are getting it. I think what I wanted to raise, though, as a final point on this is that the Biden administration has identified a few $100 million more now to the H5N1 outbreak for testing, for building up the vaccines and stockpiles. And what they need to be doing more of, and what is coming out more and more, is we need to figure out how to give the farmers incentives to identify their herds and their workers. And it's complicated by the fact that a majority of their workers are undocumented. And so they're not as keen to be entered into the healthcare system.
Especially right now.
Right now, exactly. So there are big problems going on at this moment. The last point I'll make is that there are several people that we know who we respect, including Scott Gottlieb, our former FDA commissioner, who have really gone on the record more and more in the last couple of weeks to say that we've got to be doing more. I agree with them. I'm just not sure politically it's as easy as they think. Like the farm bill that just got approved 2 weeks ago could have included $1 billion just for H5N1. I don't think either party was eager to push that on there right now.
Yeah, I can see that. And just to be clear, you've heard about this virus in China now. There's a virus that's kind of circulating. That's different than this.
That's right.
And it does seem like it's also people get sick, but people aren't dying as a result of it. They are closing some schools, I heard, to try to slow the spread of this. They're going to be in the same position trying to figure out what they want to do, but it's not COVID.
No, that's right.
Meaning that obviously the virus is different, but it's not that kind of situation. I only say that because I saw on social media, there were some inflammatory things being written about and there's this new virus in China. By the way, that's not a new virus. It's a virus that's circulated before. These things are going to happen. It's not one that's eliciting the same kind of concerns. For example, I think that the bird flu might, if it really jumps to humans.
And look, if people are really concerned, be concerned about the United States right now, where we have pretty bad outbreaks of RSV. COVID is getting worse again, and flu, general flu. And we're seeing so many cases.
By the way, lots of people very sick right now.
I've never seen in a short period of time, other than COVID, as many chest x-rays with positive findings as I've been seeing in the last couple of weeks.
Yeah, and heard from a lot of people that they've been sick. And I told you I was sick.
Yep.
Let's jump a little bit, because since you're going to go see the Surgeon General tomorrow, and that he came out sort of as his final salvo, with this report about alcohol and cancer warnings. And there were a couple things that interested me about this. So this is a report that's laying out the risk of cancer associated with alcohol, and saying how it's tied to 100,000 cancer cases and 20,000 related cancer deaths in the U.S. annually. Something, I think we pretty much know and accept.
It's in the literature.
It's in the literature. And, I have felt for some time that there is this growing momentum, appreciation of the toxicity of alcohol. Of course, we've always known this. There's so many ways that alcohol causes harm. It causes harm in overt ways for people who are at the far end of the spectrum of being alcoholic. And we see diseases, so many diseases associated with it. I was glad to see him come out with this. I think it's a good trend if people start paying attention, at least recognize this. Our culture is so oriented towards alcohol and social behavior. You can't go out to dinner without people talking about offering a drink. At least people need to know what they're signing up for with this. Even a small amount of alcohol can increase risk. There was one part I was just going to talk about for a minute, which is there still is this, I'll call it a myth, persistent belief that a small amount of alcohol can be cardioprotective. People sort of introduced this idea because this was this French paradox. People were drinking alcohol in France, and they have lower than average cardiovascular risk. And people were wondering if this is this. A lot of epidemiologic studies have been conducted where it seemed like there was this, what they call a J curve, where You know, that it's even flatter than that. You know, it's not even going up at low, but it jumps down at 1 or 2 drinks and then it starts to go back up. For many of us, I'll just speak for myself, I've often felt that it's very hard in these studies, just as it is in these food studies, to disentangle the potential confounding. You know, who has a drink or 2 a day? A lot of times people who drink nothing historically were people who had trouble with alcohol or had trouble with health.
Right.
And so they gave up alcohol because there were health issues. So when you start looking at this, it was hard to disentangle that. There was a series of studies that really intrigued me. You know, Howie, that there is this gene that can cause flushing if you drink alcohol.
Yes.
There's alcohol dehydrogenase.
More common in Asians, I think.
More common in Asians, but there are people who have this gene who essentially are intolerant to alcohol.
Right.
They have this unfortunate, I don't say unfortunate, maybe it's
Maybe
fortunate.
it's fortunate, yeah.
Yeah, they have an adverse effect to alcohol that they vasodilate because they don't metabolize it correctly. If you look at this on average, people with this don't drink very much because they have a negative reaction to it. So they've done studies, they call these Mendelian randomization studies, where they look at people who've got these genes, then they can follow them over time, believing that they probably have had less exposure to alcohol than those who don't have the gene. And when you do these studies, when you're basically saying this is a marker for alcohol consumption and so forth, you know, you don't see this lower, you know, you don't see this piece where people aren't drinking, who are drinking a little bit maybe, are having a protective effect. Because they can see a sort of dose response in terms of how much of a reaction you might have with this. I don't know what the answer is. I will say this: no one's proven that 2 drinks a day are good. I wouldn't tell a patient to drink 2 drinks a day to be protective. If somebody wants to drink, they can drink, but I don't think they should drink because they think it's heart healthy. I have a question. Do you drink alcohol?
I don't. As you know, I think you know, I stopped, during an illness 14 years ago, 15 years ago almost now. And starting about 2 or 3 years ago, I started having non-alcoholic beers. And I've wondered, like, if there's any data about non-alcoholic.
Because you like the taste, or because it for you, it's like reminds you of.
I've come to love the taste, and it's funny because I don't know about your experience, but the first time I ever tasted beer, I thought it was horrible. But by the time I quit drinking, I enjoyed having a Guinness every night.
That's interesting.
And now I have a non-alcoholic beer more often than not every evening.
That's interesting. Yeah, and I think you know that. I mean, it's not that I wouldn't take a drink, but I actually basically don't drink anymore. And part of it is this idea of cognitive function, aging. You know, it's just I just don't think. I don't need it. I don't miss it. And I think if I'm trying to do everything I can to maintain my health and to
I agree.
maintain my sharpness, you know, then I don't.
Yeah. And I do want to give just the magnitude of the effect in his report to our listeners because, you know, in women, drinking 2 drinks a day would result in 5 extra cancer cases per 100 people. And in men, it's 3 extra cancer cases. That's not insubstantial. Like, cumulative effects matter.
Yeah. I think if we didn't have alcohol in the society, think about cancer of the esophagus, cancer. I mean, there are lots of different kinds of cancers that would probably be a lot lower. Yeah.
So if it's okay, I think I'll pivot to another topic around cancer just really briefly, and that's survivorship. And this is just a quick comment, but in the Journal of National Cancer Institute just 2 months ago, I just noticed it though, they talked about just how many people have survived cancer now. There's an estimated 18.1 million U.S. cancer survivors, expected to increase to 26 million by 2040. 70% had lived 5 or more years after diagnosis, and 11 had lived 25 or more years after diagnosis. My brother-in-law being a good example of that. And they go on and they give us more statistics. But the bottom line is that this is a growing population, big numbers. We have had 2 guests on in the last couple of years, Hill Moss and Tara Sanft, Dr. Tara Sanft, who have talked about survivorship and survivorship clinics and how do you provide services to them. But I just want to mention again and ask you what you think in terms of the evolution of medicine. Like, how are we doing in serving these populations? Because my sense, partly from my brother-in-law, partly from talking to other patients, is that there's a rare number of physicians who are really skilled at coordinating the type of healthcare that people who are far out from cancer survivorship but have complications related to their chemotherapy, their radiation therapy, or general surveillance that they still need for other cancers and their original cancer.
Well, I'm a big fan of thinking about the entire trajectory of people's interactions with illness. And we were raised, I was raised as a resident to kind of, someone came in the hospital, they left the hospital, you declared victory, and, they went off on their
Right.
own. And in the outpatient world, in the wild, that people are sort of, can you get an appointment? Can you get, who's going to see, who's coordinating things? It's not very good. That's why I started looking at readmission intently. I hope we're moving to an era where we're recognizing the illness from the perspective of the patient. We have often had the perspective of the healthcare system. And then so we look at these junctures of care. They show up in an office, they are hospitalized. But for a patient, that journey is a very different journey. It's a journey of, I'm going different venues, but it's a longitudinal journey, one in which there's a need for intense coordination. Cancer highlights it, but you're seeing this in lots of different areas. Autism and I was talking to someone even about someone who's had a cardiac arrest. Someone has a cardiac arrest, they get resuscitated, they leave the hospital. Everyone says that was a great save. Maybe they get, a diagnosis of what caused it. Something's addressed. Maybe they get defibrillator. But what we're learning is that people have intense psychological effects after having one of these near-death experiences. So it's not just one and done. It's
Right.
about what's the trajectory of their struggling with this illness? Even if you address the heart, you've got to think holistically about this person's journey. They have PTSD after having one of these events.
Without a doubt.
And then I'm just going to broaden it to all the caregivers around this person, right? So the impact of the illness is one that has ripple effects out, beyond the individual. I'm hopeful that these kind of things that are cropping up will address it. What I'm worried about is that we continue to micro-segment healthcare.
That's
so
the
that,
problem.
if I've got 3 different problems, and now here's the group handling the cancer, here's the group handling the heart failure, here's the
Right.
group handling, my mental issues, where we need this sort of holistic approach.
And by the way, we got a nice comment from one of our listeners who is a family practitioner and who made the point after a comment I made on a prior episode that there are family practitioners who do a great
Yeah,
job
that's right.
of coordinating care. But what I would say about cancer survivorship is that's a whole different kettle of fish. You go through sometimes years of intense follow-up with your oncologist just dealing with the major problem and maybe a couple of comorbidities, and then you're discharged as cured, but you still have a lot of things that need to be attended to. And
there are risks that accrue because of what you've just been through, right?
Exactly. The chemotherapy, the radiation, the stress, everything.
Secondary cancers, heart disease. It depends what you've been through. And then I'm just bringing up the mental health issues don't end.
That's right.
They don't end. You still worry. There's lots of things.
So I hope we can do a better job with that. I do think it's challenging, and I think it's a challenge for all of medicine, not just for one specialty.
Yep. I was going to just raise one thing to you. Just again, this is a bit quick hit, but one thing I'm keeping my eye on is this issue about the ultra-processed foods. And I say it because there's some possibility that Robert Kennedy Jr. will be the next person who leads HHS, and this is a big area for him. And even though I did see him, what did he do? He deep fried his turkey in taro. Did you see this
No, I
for
hadn't seen
Thanksgiving?
this.
Yeah,
No.
no, I don't know. But maybe that's okay because not ultra-processed from his point of view. But there's continuing research and a drumbeat about the harm from metabolic dysfunction, systemic inflammation, whole range of things. It kind of crept up on us that so much of the food that's eaten by so many people in this country end up being this ultra-processed food that, we were worried for a while just about the salt content, but it's not just the salt content.
Oh, my God, yeah. No, look, I was just saying before we got on the podcast, Miranda, our producer, is here with us virtually, and I was just saying to her, probably the worst thing I eat are my protein bars. I mean, most of the protein bars I eat have all these chemicals in it.
When you look at the ingredients, you don't recognize most of the stuff
Exactly.
that's
It's
in there.
terrible.
Yeah, so I'm just keeping an eye on that. I'm just wondering, because, the one thing about this ultra-processed food, here's a story I'll tell you, which is I was talking to someone from PepsiCo, but my friend George Mensa, who was working there for a while, and they were taking trans fats out of the Doritos. And so they were saying, in the U.S. we got all this stuff. And then he was telling me, but in different countries, they have different rules. So I happen to have been traveling to Egypt for a healthcare project. At the time, I said, well, what about like Egypt, for example? He goes, oh, yeah, that's full of trans fats. And he goes, I was there, and I tasted one. I'm going like, well, what did it taste like? He goes, it was delicious.
I believe it.
So I mean, that's the problem. I'm curious to see how the politicians are going to be able to address this when a large segment of America is hooked on this stuff.
It would, as a beginning, it would be great if we could figure out how to do the proper studies to figure out what the harm is, because we don't really have answers to that. It is really hard to test these things. It's hard to do a purely randomized trial on them. It would be great if we had more answers to that.
Yeah, I mean, they took the trans fat out of New York. They have done some studies, but it's still hard to tell how many people were saved as a result of that change.
And we've talked about the erythritol issue and the other sugar alcohols. So
that's right.
So look, I want to go back. We started off talking about what happened with United Healthcare, and the health insurance industry has been vilified, and they deserve some of the opprobrium. But I did want to talk about some other bad behavior. The Department of Justice announced a $17.7 million settlement against cardiology groups in 12 states about overbilling of Medicare.
I was going to bring up that thing in radiology. See that thing in
Florida?
I'm going to that second. You are going?
Yeah,
I was going to say, if you're
giving equal time.
If you're going after radiologists, I just wanted to be sure.
Yeah, equal time. So I have no doubt that some overbilling occurs without fraud or deceit. People make mistakes, okay? But when one of the settling groups was a single cardiologist-led group with $6.7 million, and he is actually settling with the Department of Justice, you know that there's bad behavior going on there. And like I said, I just want to give equal time to radiology. Aetna has accused, this is not the Department of Justice, but Aetna has accused a very, very large radiology group owned by private equity investors of grossly inflating their billing to both collect more money and use the Federal No Surprises Act to their advantage. One example from this filing is the interpretation of a chest X-ray, which in the worst case scenario could take me a minute. In the best case scenario, it could be 10 seconds. They inflated the price from $14.50, what they get reimbursed, $14.50, to $252.12.
Okay, but I read a lot about this, and I was going to raise this with you. This is a very interesting thing that happened. I had heard some of the X-rays were $7, some were $77. I didn't hear the 14 to 250, but you said. But what I understood that happened was that, as you know, depending on your arrangement and negotiation with the payer, there are different rates floating around.
Correct.
Actually, this crazy amount of range that you're talking about, 10x or more range, you're talking 20x, range of payment. And so what they did was they were acquiring practices and putting the charges through the group that had negotiated the highest price. But you and I have seen this because there was a similar thing happening all around the country where health systems were purchasing private practices so that they could bill their services under the health system negotiated cost for, say, an echocardiogram.
Correct.
That was maybe 2x, maybe 5x or 10x. So I think we have to come to terms with, why isn't there a standard amount that's being paid for something? Everybody's got a different deal. And this is, as I read it, more of an arbitrage activity, which was somebody has got a higher negotiated payment for this. Let's all come under that tent and we'll all do better. That's what a lot of health systems do.
No question. I think in this case, what they're doing is not only collecting this enormously inflated number.
Well, why are you calling it inflated?
Because Medicare, which is statutorily required to pay cost, would say a chest X-ray is about $9.50, or maybe it's $10.
The interpretation?
Correct. That's what it is. And this is interpretation
When
only.
you do an interpretation for Medicare, you get paid $9?
About that.
Wow.
Yeah. And by the way, you can make money off that. Not a lot, but you can make money off it, because if you're reading 40 an hour, which you can do for probably 4 or 5 hours in a day, that's not a terrible. It's not a terrible. Yeah.
Wow.
I mean, you can make money off of it.
You were the business guy in radiology, so if anybody knows you can make money off it, you can.
Look, and I'm not saying anyone wants to be building a practice around chest X-rays. Most radiologists would say it's probably more fair to get paid $20 or $25, but Medicare can get away with paying $9 or $10. $250, $212 for the interpretation is so outside
But somebody,
the norm.
it's not fraud. Someone negotiated that
It's
payment.
their fee schedule.
I know, but somebody negotiated. Well, somebody could have easily said, "I'm not paying that much to you." Why did they say yes?
So I'm not even sure if it's actually within network for Aetna. It was,
that was the
Yeah.
thing.
Yeah.
They pulled out of the network, and they were calling a lot of these out of network. That was another part of it.
Yeah. So there's a lot. All I'm saying is, you want to point fingers at United Health Group, go right ahead. There's a lot of bad behavior there. Aetna, all of them have done bad things. But our physician brethren and sisters, I guess, as well.
Please.
There's
thank
bad.
you.
There's
Thank
bad,
you, Howie.
There's bad behavior out there.
I don't want to be getting letters.
No. There's bad behavior
Appropriately
out there.
letter, getting
Yes.
letters. But this is, I think, isn't this why we hate the fee-for-service system? I mean,
Everything.
It just is. It reduces everything to transactions. It now we're fighting over the amount. It's like,
we would be so much better off if we figured out how to get to a more population health-based system. We talked to Jay Wanru just a month or so ago about how Geisinger has population health-based delivery. We would be much better off if we got to that type of payment.
Well, this is a great way to kick off the year. It's so much fun being here with you. I really feel like, gosh, Howie, I have no idea what's going to happen with this next administration. The leadership, the fights, what are going to be the priorities.
There's a lot to talk
this
about.
was the administration that wanted to eliminate Obamacare. They seem to have softened on that now.
But they are without a doubt looking at Medicaid right now. And 1 in 4 people in America gets health insurance through Medicaid. I don't blame them for looking at it in the sense that if you're looking for budgetary savings, Medicaid is where you have to look.
And the thing that is going to be so interesting, we'll have a lot to talk about as things progress, is that they're going to be able to pass a lot of things because there's a sense in the country that this wasn't his first election and more of a split. But whether you believe he got a mandate or not, and there's controversy about how much he won by and whether he got a mandate, there's a sense on the Hill that this administration should be allowed to pursue what they want to pursue and see what happens.
His party controls the House, the Senate, and the executive branch. He did get...
Some people would say part of the highest judicial.
That's right. I mean, I think we're going to see them testing how much of a mandate he has. And I do think you're going to see major legislation passing, and I do think healthcare is going to be part of that. And I hope that we, the best of us, are able to protect those who are.
There could be some good things, and I brought this up before. This administration, because it was sort of immune to external lobbying, they just did what they wanted to do. I was sitting in the office with Secretary Azar, and they were talking about we have to make sure people get access to their medical records. And they were just going to do it. No matter what kind of resistance there came from the status quo, there is the possibility that there are some good things that can accrue out of an administration that is going to
take the bull by the horns. Look, I am very cautious. I saw him give a talk this morning at a press conference that was very disturbing to me. But I remain of the opinion that I'm not going to worry about what he can do. I want to see good things come out of them. If there are good things, I'll applaud it. If there are bad things, we must do everything we can to highlight for the public why it's bad and hope that Congress responds appropriately.
And I think that's what we should be doing with any administration, which is we shouldn't reflexively say one thing is good or bad. Everything should be evaluated in its own right, and we should be able to reason why that is. So it's going to be a very interesting time. We're on the cusp of this. Next week, on our podcast will be days from the transition. It's hold on tight.
Absolutely. One last thing I'll say about the presidency, though, is on Thursday, the day that this gets released, is Jimmy Carter's memorial service. Yeah. We have talked many times about his legacy.
Gosh. What a contribution to the world's health.
That's right. Really, rest in peace, Jimmy Carter.
Yeah, and we should always reflect on what he did. Yeah. You've been listening to Health and Veritas with Harlan Krumholtz and Howie Foreman.
So how did we do? To give us your feedback or to keep the conversation going, email us at health.veritas@yale.edu or follow us on LinkedIn, Threads, Twitter, or now Blue Sky.
And we're eager for your feedback, so please rate us. That helps people find us. We listen. We often talk about it on the air, so We value our listeners, and we're eager to hear from you.
We've been getting more and more emails and feedback, and we try to incorporate it into as many episodes as we can. If you have questions about the MBA for Executives program at the Yale School of Management, reach out via email for more information or check out our website at som.yale.edu/EMBA.
And our podcast is sponsored by the Yale School of Management, the Yale School of Public Health. We're fortunate to have one of the world's greatest producers, Miranda Schaefer, working with us, and Howie has recruited from his classes and his networks some of the most amazing Yale undergrads that we've ever seen. So Sophia Stump, Ines Gil, Tobias Liu, and we're just so lucky to be working with them.
And we're just excited to continue the podcast. So Happy New Year to everybody, and thank you, Harlan.
Talk to you soon, Howie.
Thanks, Harlan. Talk to you soon.